This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the 2026 edition of the journal Clinical Neurology and Neurosurgery.
This paper touches on a scenario we see quite frequently in our practice, the management of vestibular schwannomas, or VS. Specifically, the researchers looked at gamma knife radiosurgery, or GKRS, and its role as an adjunctive treatment.
Right. We often use GKRS for residual or recurrent tumors after a patient has already undergone a surgical resection. While GKRS is generally considered a safe and effective option for tumor control, there's always been a question mark regarding the cumulative risk to the cranial nerves, specifically the facial nerve.
Exactly. When we talk to residents and medical students about VS, we always emphasize the preservation of the facial nerve. It's the holy grail of VS surgery. But the literature has been somewhat sparse on whether a prior surgery actually changes the nerve's tolerance to subsequent radiation.
And that's exactly what the study aimed to address. They investigated whether prior surgical resection is a predictor of facial nerve function decrement after radiosurgery. For those listening who are deep in their clinical years, decrement here refers to any measurable decline in the House-Brackmann score, or clinical function post-GKRS.
It's a crucial distinction. We know that primary GKRS, using it as the first-line treatment for a small to medium VS, has excellent facial nerve outcomes, often cited at over 95 to 98% preservation. But this study suggests that the adjunctive setting is a different biological landscape.
It really is. The study's core finding is quite direct. Prior surgical resection is a predictor of facial nerve function decrement after radiosurgery.
Let's pause on that. As neurosurgeons, we have to ask why. From a surgical perspective, if a patient has already had a subtotal or near-total resection, that facial nerve has already been handled. It's been dissected off the tumor capsule. There might be changes in its vascular supply, the vasa nervorum, or perhaps some degree of post-surgical scarring and tethering within the internal auditory canal or at the cerebellopontine angle.
That makes sense. The paper notes that while GKRS is effective for the residual or recurrent tumor, the nerve may be more vulnerable. If the nerve has been anatomically thinned or stressed by the initial surgery, its physiological reserve to withstand the ionizing radiation from the gamma knife might be significantly lower compared to a virgin nerve that hasn't been operated on.
And for our residents listening, this changes how we counsel patients. If you have a patient coming in with a recurrence after a prior translabyrinthian or retrosigmoid approach, you can't necessarily quote them the same low risk of facial palsy that you would for a primary GKRS case. According to this data, the history of surgery itself is an independent risk factor.
It's an important nuance for treatment planning. When we look at the dose volume histograms and the marginal dose, typically 12 to 13 gray for these tumors, we have to be mindful that the facial nerve in a post-surgical bed might not be as resilient as the textbooks suggest for primary cases.
Now, the study highlights that GKRS can serve as a vital adjunctive treatment. It's not saying we shouldn't use it. It's saying we need to be more predictive about the outcomes. Alara, did the study mention the timeline of this decrement?
The focus was primarily on the fact that prior surgery influences the risk of injury. It underscores that our understanding of facial nerve injury from GKRS was, until now, poorly understood in the context of prior resection. This study helps fill that gap by identifying surgery as a clear predictor of decline.
This is a call for us to be more precise in our multidisciplinary clinics. When we discuss a planned subtotal resection followed by GKRS, which is a common strategy to preserve the nerve in large tumors, we must acknowledge that the second hit, the radiation, is landing on a nerve that has already been through a major intervention.
Precisely. It really emphasizes the importance of longitudinal follow-up for these patients. We can't just assume that because the surgery was successful and the nerve was intact post-op, the GKRS will be free of facial nerve consequences.
Great summary, Alara. To wrap up, for those of you in the clinic or preparing for boards, remember that for vestibular schwannomas, a history of surgical resection is a significant predictor of facial nerve function decrement following subsequent gamma knife radiosurgery.
It's a key piece of the puzzle in personalized neurosurgical care.
That's all for today's episode. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you next time.